Hello, I'm Deirdre Bruno, a nursing student at Aspen University, and this is my presentation on musculoskeletal difficulties. The first one I'm going to discuss is degenerative disc disease. Intervertebral discs separate the vertebrae and they work as a cushion to help absorb shock in the spine. It's also an age-related condition that happens when one or more of the discs of the spinal column begin to deteriorate or break down. It may not always be painful, but if the disc herniates or stenosis occurs, pinching nerves happen, and that causes the pain to be generated. It's also worse in patients who have had previous spinal injuries. Next, the spinal disc, it can lose its flexibility and shock absorbing abilities during the aging process, usually around 40. The disc has become thinner and the inner gelatinous fluid of the nucleus populus begins to dry out and shrink. This causes the disc to be unable to bear weight and distribute it normally, so the pressure comes down around the surrounding areas. As the pressure is transferred to the annulus fibrous, causes progressive destruction. The torn area results in the herniated disc because it presses against the spinal nerves emerging from the interval foramen, and that causes radiculopathy. Now, radiculopathy is feelings of pain that radiate down the extremities, tingling, numbness, just decreased strength, and limited range of motion. Diagnosis is completed through obtaining a complete patient history, physical examination, imaging, and diagnostic procedures. For instance, the X-ray can identify the structural defects. CT, MRI, and myelograms can locate the areas of damage. An epidural, venogram, discogram are all useful if the other diagnostic studies are inconclusive. Also, an EMG, it can determine the level of nerve irritation, and it eliminates peripheral neuropathy is one of the causes. And then the symptoms that present include pain that's worse when sitting, because when you're sitting, the back has to hold on to like 3 times more pressure and weight than when you're standing. Pain that gets worse when bending, lifting, twisting. If you feel better while walking or even running than standing or sitting for long periods of time. If you feel better when you change positions often or lie down. Periods of severe pain may come and go. They can last from a few days to a few months. It can become nagging, disabling, and the pain can be felt in the low back, buttocks, thighs, or neck, depending on where the affected disc is, and it radiates down the arms and hands, creating tingling and numbness. Weakness in the leg, muscle, or foot drop are also positive signs of damage to the nerve root. So some of the nursing interventions include identifying the location, onset, duration, and factors that increase or decrease the pain. Vital signs are important because of elevated blood pressure, heart rate, or respiratory rate are signs that maybe pain is being ineffectively managed. Also, drug allergies should be noted because the doctor may want to begin pharmacological therapy. So the nurse on their own can introduce cold or heat therapy or gentle stretching as a non-pharmacological intervention. The interventions depend on the level of severity. Conservative treatments include weight loss, oral analgesics, physiotherapy, acupuncture, chiropractic adjustments, and pain injections. More extensive treatment includes decompression therapy, total disc replacement, and spinal fusion surgery. Chiropractic adjustments, physical therapy, gentle core stabilizing exercises like yoga or low-impact aerobics have been proven effective complementary management for degenerative disc therapy. And one study did find that when they used the Oswestry Disability Index and the Visual Analog Scale before and after exercise, that the pain score for the condition decreased significantly from 6 to 12 down to 2.43 on the Visual Analog Scale. and the limit of daily activity is decreased significantly from 20.18 all the way down to 8.81 on the Oswestry Disabilities Index. So just strengthening those core areas really can make a huge improvement in daily activity and daily life. So some of the more invasive procedures, surgical procedures, we have the intradiscal electrotherapy, Plasidy, or IDET, which is a needle inserted into the affected disc with an X-ray guidance. The wire is heated and then and threaded through the needle, and it destroys all those nerve fibers. Similar to that is the radiofrequency discal neoplasty. Radiofrequency probe is placed through that needle. The energy generated breaks up about 20% of the nucleus and reduces pressure on the disc and surrounding nerve roots. Also, we have the X-stop, which is the interspinous process decompression system, where a titanium device is placed in the vertebrae in the lower back and works by lifting the vertebrae off the pinched nerve. They have the lumpectomy and discectomy. Both are surgical procedures, involves incision where they, into the vertebrae, they remove the protruding disc and replace it with an artificial disc. So the artificial disc can be replaced with a high-density core cobalt corneum plate is another one. And then spinal fusion is used to give more stability and decrease vertebral motion. So some of the nursing diagnoses, there were several, but chronic pain is one of the main ones with this condition. So chronic pain related to inflammation of lumbar spine is evidenced by the patient reporting consistent lower back pain for a year, disruption of normal activities, decompression or depression, fatigue, and rubbing of the painful area. So for the outcome goal, the patient will list 5 non-invasive pain relief measures to help manage the pain during this clinical visit. Also, the patient will verbalize how to correctly take prescribed per diem medication for his back pain during this clinical visit. So the interventions, the nurse will educate the patient on 5 non-invasive pain relief measures to help manage the patient with the pain. The evidence practice states that pain causes cognitive impairment. So if it's already being somewhat managed with pain medication, that additional therapy will help decrease the likelihood of them being distracted and unable to rest and causing the cognitive impairment. Next, the nurse will teach the patient to use non-opioid analgesic and how to correctly take the prescribed per diem medication for his back pain. The evidence practice is non-opioids such as NSAIDs and Tylenol are first-line analgesics for treatment of mild to moderate pain conditions like osteoarthritis pain. Evaluation, the patient was able to list 5 non-invasive measures of pain relief, such as hot cold therapy, gentle stretching, core strengthening exercises, restrictive activity during flare-ups, allowing time for rest, analgesics, and utilizing a back brace for support. Second, the patient was able to correctly take prescribed per diem medication for his back pain. For example, taking as directed, do not take more than recommended dosage, use over-the-counter medications like NSAIDs, Tylenol, or analgesics first. And then for pain with spasms, you may use muscle relaxers, but do not drive or use any machinery. And then the second degenerative condition is osteoarthritis. The main difference between osteoarthritis and degenerative disc disease is that degenerative disc disease affects the intervertebral disc, and osteoarthritis affects our auricular joints. The pathology of degeneration and treatment options are similar. Eventually, both will suffer from degenerative changes, leading to the destruction of intervertebral disc or articular joints. So osteoarthritis, it occurs when the cartilage that cushions the ends of your bone gradually deteriorate. The cartilage is a firm, slippery tissue that enables nearly frictionless joint motion. Eventually, if it wears down, you'll have bone on bone. And then some of the causes include age, obesity, injured or overused joints, genetics, muscular weakness, and other types of arthritis which damage the joints. As the disease progresses, the usually smooth, white, translucent articular cartilage becomes dull and yellow and granular. Eventually, the cartilage can become harder and less elastic. Heavy use causes it to wear out quickly, and it happens so quickly it's impossible for the body to repair it. And then during the articular wear, the cartilage becomes cracked and worn out due to the changes in collagen structure. And at the edges of the joint, the cartilage may become thicker and osteophytes form. And the joint surface becomes uneven and decreases movement. So some of the clinical features are that, as opposed to most pain, which typically gets worse with activity, joint stiffness typically starts after rest or a motionless position, and then it is usually worse in the morning, but generally subsides after 30 minutes. It actually helps to get up and move around with osteoarthritis. It loosens everything up and the pain is lessened. So this helps distinguish it from other inflammatory joint disorders like rheumatoid arthritis. Also, it occurs asymmetrically on one side of the body in the joints rather than bilaterally. And then you may see a physical appearance of something called Herbert's nodules, which is the interphalangeal joints of the fingers become deformed with those osteophyte growths. And then diagnosis, it occurs with a thorough patient history and physical examination, knowing where the pain's located, how the disease progressed, if there's family history, how daily activities have been affected, and if there's been previous joint damage. Diagnostic tests are important, like bone scan, CT, MRI, to detect the early joint changes. X-rays can identify the stage of the joint damage. And as it progresses, the x-rays may often show a narrowing of the joint space and increased dense bone. Once again, you might see those osteophytes physically, like those nodules in the fingers. Lab tests and biomarkers aren't as useful because inflammatory markers that you see in most inflammatory arthritis, like rheumatoid, the ESR is actually normal with osteoarthritis. And then another thing is that the inflammatory markers like synovial fluid analysis can also differentiate it from other arthritises because the fluid's yellow and clear with little or no sign of inflammation. So those markers usually rule out the others so that you can lean on the clinical presentations that are showing to make the diagnosis. Next, management depends on the level of progression. Physiotherapy, anti-inflammatory drugs are used to alleviate symptoms such as overloading and inflammation in the early stage. However, they only delay surgical treatment, and most patients eventually undergo arthroplasty for the damaged joints. So some of the non-pharmacological therapies for osteoarthritis includes weight loss, exercise, strengthening, splinting, alternatives like Tai Chi or yoga, acupuncture, massage, or use of TENS units. Also, orthotics and assistive devices are helpful with activities of daily living. Some of the drug treatments include oral, topical, or injectable medications, such as Tylenol, NSAIDs, diclofenac gel, monoclonal antibodies. Croton and glucosamine are some orthopedists are on the fence about whether they're helpful or not, and then the S, adenosylmethone. Then we have some of the major complications associated with osteoarthritis are fatigue, joint deformity, and joint damage. Nursing diagnoses for osteoarthritis: impaired physical mobility related to fatigue, restricted joint movement, stiffness, pain evidenced by limited range of motion, decreased muscle strength, and reluctance to transfer or perform your activities of daily living. So client will perform physical activity independently or within limits of activity restriction. And then the second one, client will demonstrate the use of adaptive changes to promote ambulation and transferring. For the nurse intervention, the nurse will assess the client's ability to perform activities of daily living and determine what adaptive measures the client's already taken to perform those self-care measures. Also, they will consult physical therapy staff to prescribe an exercise program. So for the first one, if a person has a joint deformity, especially in the hands that occur with OA, it may limit certain self-care activities by the client. A spouse may have to assist with buttoning, picking up clothes, or picking up dropped objects. If the patient had an assistive device, they will be able to maintain more functional independence. And then for the physical therapy, the rationale is that the therapist can help the client promote muscle strength, joint mobility, and therapies to promote relaxation of tense muscles. These interventions also contribute to effective pain management. So for evaluation, the patient demonstrated physical activity independently within the limits of activity restrictions during this visit by utilizing a sock donor and elongated shoe horn by applying socks and shoes. So therefore, the intervention was effective. And then for the last evaluation, the patient demonstrated use of adaptive changes that promoted ambulation and transferring during this clinical visit by using a cane to offload the weight from the affected knee joint. So that is my presentation, and I thank you so much. Have a good day.